compatriots, Nigeria's call obey, to serve our fatherland with love and strength and faith. The labor of our heroes past shall never be in vain. To serve with hearts and minds, one nation bound in freedom, peace and unity. May we please recite the first stanza of the national pledge. I pledge to Nigeria, my country, to be faithful, loyal, and honest, to serve Nigeria with all my strength, to defend our unity, and uphold her honor and glory. So help me God. Thank you, my lords. Please be seated. At this stage, may we please invite the Honorable Justice C.E. Nwosu Iheme, JCA, the presiding justice of the Owerri Division, to please lead us in the Awka Division. I stand corrected, my lord. To please come to the podium and lead us in the opening prayer. Thank you so much, my lord. I'm most grateful.
Does this come out?
Yes, it does.
May we rise in prayer. Our Father and our God, Almighty and most merciful Father, God of glory, God of majesty, Lord, we worship you, we praise you, we celebrate you this evening the way we celebrate you all the time. Thank you, dear Lord, for the mystery of sleeping and waking up hale and hearty. Thank you, Lord, for graciously allowing us to see December 2020. It's been a challenging year, a very unusual year, particularly because of COVID-19. People have died in hundreds of thousands. And here we are, cruising almost to the end of the year. Thank you, Lord. May we never take your goodness for granted. Thank you, dear Lord. Lord, you abhor digression, you abhor injustice, you abhor double standards, and you abhor discrepancies. Lord, few of our judges and our justices deliberately come out with unjust judgments, not because of poor knowledge of the law, but due to pressure, and thereby making a mockery and a caricature of that prefix, that title, justice. And we know, Lord, that every unjust judgment must be punished. Deliver us. Lord, we often pray for success in life. And when you grant us that success, Lord, majority of us are unable to manage success successfully. Forgive us. Lord, this is the month of December, a month of sober reflection, when we celebrate the life of your Son, Jesus Christ. Lord, most of us, rather than celebrate the life of Jesus Christ, we celebrate ourselves. Forgive us. And may the life of our Lord Jesus Christ, the circumstances of his life, may it instruct us. And may you grant us, Lord, the humility of the child Jesus. Forgive, dear Lord, our gross misuse of your grace. This is our prayer, and we make it in the name of God the Father, the Son, and God the Holy Spirit.
Lord, Honorable Justice C.E. Nwosu Iheme, Presiding Justice, Awka Division, we thank you very much, my Lord. We shall now move on to the paper presentation for today. It is a paper presentation that is very important indeed because, as they say, health is wealth, and more so for your lordships, whom we value very much for your experience and contribution to society. The health problems do come from giving the name of the job. So this presentation will help us to address some of the biggest health issues that affect people of the judicial class, and hopefully with the presenter we have, we should be able to give solutions to that. And the chairman of session for this particular day is my Lord, the Honorable Justice Oyebisi Folayemi Omoleye, JCA, who before I invite the chairman, may I please render a few words to introduce your lordship. My Lord was before her appointment as a judge in Ekiti State at the Ministry of Justice, Akure, for several years, where she performed excellently. And my Lord holds the distinction of being the first female chief judge in the history of Ekiti State, following her appointment to that office on the 1st of April 2003. My Lord proved to be a peerless and fearless jurist at the High Court, and little wonder then that she was further elevated to this honorable court on the 8th of June 2006, where she has adjudicated since then. She has served in various divisions, including the Benin and Akure divisions, respectively. My Lord has also been presiding justice in, amongst others, the Yola division, and is currently the presiding justice of the Akure division of the Court of Appeal. My Lord has headed several panels in high-profile cases and is reputed to be a meticulous and hard-working jurist. My Lord, you're most welcome, and we are pleased to have you at the high table. Thank you very much, my Lord.
My Lord, the Honorable the President of the Court of Appeal, ably represented tonight, and my Lord, the Honorable Justice, Ado, the presiding Justice of Alveoli Division, and the Honorable Justice, Madam. Lords, the presiding justices who are here, and my other learned brothers, justices of the Court of Appeal are here, and invited guests. I want to thank the Honorable, the President of the Court of Appeal, for the privilege to preside at tonight's session. I'm indeed grateful. I want to warmly welcome each and every one of us to tonight's all-important session. I'd like to say that it's about the most important of all the sessions at this unique seminar, conference, because it has to do with the issue of our health. I'm an incurable believer in God and the power of God to do all things, especially to heal miraculously. And at the same time, I also believe that science is a blessing from God to help humanity to manage its very frail nature. That is why I personally, and I believe all of us, do not take doctors for granted. And so tonight we're going to be lectured, as you all know, on understanding and managing diabetes mellitus, breast cancer awareness, and an insight into prostate cancer by no less a personality than Dr. Hassan Garba, MBBS, MPH, MSc, a foremost general practitioner and health professional and surgeon. He is an alumnus of the prestigious Madubelu University, Imperial College London, University of Nottingham. Dr. Garba worked at the surgery department at Hammersmith in 2005. But prior to this, had also worked as the medical officer in charge of the General Hospital, Dustinman, from 1985 to 1986. Surgery department of Kaduna Polytechnic Clinic, Kaduna, from 1987 to 1989, and the State House Clinics from 1990 to 2014. In 2014, he became a director of the Federal Ministry of Health and worked in this capacity until his retirement from public service in 2017. He has been the medical director of the Priority Clinics Limited, Garaki, since 2017 and remains actively in the service of humanity through the field of medicine. I most humbly present Dr. Hassan Garba, our paper presenter for tonight. Say the taste is in the pudding. So we are waiting eagerly to be educated with respect to the listed subjects.
The President of the Faculty, Honorable Justice Mellitus, ably represented by Honorable Justice Alveoli, Honorable Justice of the Faculty present, Chief Registrar of the Faculty present, ladies and gentlemen. It is a great honor for me to stand here before you. There are three papers of very, very immense importance. Why? Because second, because they are not very known, and those who know about them don't know about management. We want to be very clear and two genders. So we are taking prostate because it's the commonest cancer in males, and we are taking breast cancer because it's the commonest malignancy in females. We decided to take diabetes because of its prevalence and is common, and from my estimation, about 15 to 20% of the honorable justices of the Court of People are diabetic or are pre-diabetic. So I thought that we should tell you about three things to do with diabetes. Number one is to recognize it. Number two is to understand it. And number three is to manage it. So that taking much of the time, please permit me to go on understanding and managing diabetes mellitus. Thank you very much. The presentation is supposed to take the following format: the aims and objectives of the presentation, overview of diabetes mellitus, definition of diabetes mellitus, the types of diabetes we have, what causes diabetes, the pathophysiology, the symptoms, that's how to recognize diabetes, and then how to diagnose it. Now, how to evaluate reliable results, complication of diabetes, basic management of diabetes, and so on. The aims, like I mentioned, is to understand, to recognize, and to manage. And by the end of this presentation, I hope that my audience will be able to identify the diabetes as early as possible. They should be able to know how to delay the onset of the diabetes. They should be able to know the importance of early recognition and control of diabetes. They should be able to know and avoid complications of diabetes, and they should be able to lead a normal life as much as possible. Diabetes is the 7th leading cause of death according to WHO in 2016. It is a global problem because it is a multi-systemic disease. Sorry to say that I don't have to follow the slides as they are because of the time. By 2020, it has been estimated that 1.6 million Nigerians died as a result of diabetes and its complication. And diabetes is common among the low and middle income countries, so we cannot escape from that. It is the leading cause of blindness in Nigeria. It's the leading cause of hemodialysis. It's the leading cause of kidney transplant. It's the leading cause of amputation. And is the leading cause of diabetes and the cardiovascular events, because diabetes goes hand in hand with hypertension. So 7% of the population in Nigeria are diabetics, and more than 1 in 4 do not know how to go about it. In fact, 1 in 4 don't even know they have diabetes. About 90 to 90% are having the type 2 diabetes, and this is by no means a blessing, because the type 2 diabetes happens to be mainly among adults over the age of 40. We'll come to that as we go on. Physical inactivity coexisting with high blood pressure actually is a risk factor to developing diabetes. So you are more likely to develop type 2 diabetes if you have a predisposition, which means if you are hypertensive, you are overweight, and you are inactive. You don't have physical activity. You don't do exercise. So by definition, it is a chronic, multisystemic, metabolic disease. Metabolic in the sense that it is a hormonal deficiency, or it is a hormonal insufficiency, or it is a hormonal irresponsive. The body does not respond to the hormone, so that's why it is metabolic. By the way, there are 2 types of diabetes. Diabetes mellitus is to do with the metabolism of sugar in the body. The other type, which is not commonly mentioned, is diabetes insipidus, and it is to do with the metabolism of water in the body. I have never seen one. I have never seen anybody who has seen one. So it's just by the way. The insulin that metabolizes the sugar is produced in the pancreas. It's a flimsy organ lying on the vertebral bodies behind the aorta. We easily mistake it as a fatty tissue because it's quite flimsy. It has 2 types of cells, one producing insulin, the other producing glycogen. Glycogen is also unheard of because it also has to do with metabolism of sugar, but the reverse action to that of insulin. So there are 2 types of diabetes. Type 1 is the one in which there is total absence of insulin, and it's mostly seen in children and young adults. The type 2 is the one in which occurs in adults from the age of 40 and above, and is because of insufficiency or insensitivity of the cells to the action of insulin. So insulin resistance and insulin insufficiency is for type 2. Total absence is for type 1. And for the type 1, there is one that is called type 1A, if I may go into that. It's an autoimmune, which means your body is producing certain chemicals that specifically destroy the cells that produce insulin. The other one is called type B, in which you have an infection, maybe viral or bacterial, that infects the pancreas and destroys the cells. So in that case, it's not an autoimmune. It's not an immune thing. It's an infectious thing. So these are the 2 types. There are others that are diagnosed also during pregnancy. We call it gestational diabetes. And people who are, women who are pregnant and are found to be diabetic during pregnancy are likely going to develop type 2 diabetes later in life. So it's good for them to know so that they can be able to manage and avoid getting diabetes type 2. Okay, I've mentioned that. Now, how do you recognize diabetes? There are symptoms that are specific to high sugar level, and there are symptoms that are for the low sugar level. So for you to know that you have diabetes, mostly the sugar is high because you don't know you have diabetes, you're not on treatment. So most of the symptoms presented are increase in the output of urine. You pass urine more than necessary. You go out at night to pass urine 3-4 times. We call it nocturia. That's passing urine at night. You have excess thirst. You feel thirsty. You drink a lot of water. In fact, most patients say, I have to keep a bottle of water by my bedside at night. The other one is weight loss in the midst of plenty because you have abundant sugar in circulation, but you are losing weight because you're not using the sugar, because there is a resistance to the action of insulin. It's important for me to say that in type 2 you have insulin, but your body does not respond to the insulin. So that's the difference. You are producing, but it's not sufficient. And even if you have, your body cells are not opening the gate for glucose to go in and be metabolized for energy. They have hunger and fatigue. They get tired easily. They have headaches because of hemoconcentration. You have lost quite a large amount of water compared to what you take. So you are actually dehydrated within. So if you are to take your blood, it will be concentrated. So that's what you call hemoconcentration. And people tend to have blurring of vision because of microangiopathy, which means diabetics tend to have small capillaries because the moment one is blocked by the concentrated blood, another one will try to be made. So you have small capillaries all over. And when we check in, that's why it causes blindness in the eye, it causes kidney failure, because this is as the result of microangiopathy. Now, these are the symptoms of those who are diabetic. They are taking medicine, and they tend maybe to a little bit overdose it, or they do not respond initially, but something happens. Now the insulin, the cells wake up and they talk about the insulin. So the sugar goes down rapidly, and they get symptoms of hypoglycemia. What are the symptoms of hypoglycemia? Rapid heartbeat, sweating, hunger, fast heartbeat, inability to concentrate, confusion, irritability, mood changes, and that can lead down to coma because the brain doesn't use anything else but glucose. The brain doesn't use any protein at all. Brain recognizes glucose and uses glucose and nothing else. So you can see the importance of sugar in the body. Your sugar goes down, you go into coma. Your sugar goes high, you don't go into coma. But there are other complications that comes with it. So, but there are occasionally we see patients in the clinic that present with something else that pinpoint that check sugar. This is a sign of diabetes. Skin wrinkling, skin dryness, vaginal discharges, vaginal dryness, ED, erectile dysfunction commonly in men, loss of libido, loss of interest, wound that doesn't heal. You know, you have a small wound because your sugar is sweet. Bacteria colonizes that wound, you get infection, and it gets worse because you do not respond. Your body cannot fight that wound. So it gets infected, and at the end of the day, you find there's gangrene, the limb will die, and then, unfortunately, some lose their limbs as amputation. Some have pain during intercourse because of dryness. So these are things that are not related to sugar. They are related to the actual disease, but they are manifesting not in coma, not in confusion, not in the other symptoms that we mentioned earlier, but skin and reproductive pathologies or problems. In fact, even infertility is known to be associated with diabetes. So we diagnose diabetes. The easiest way is to take blood sugar, a blood sample, and the fasting blood sugar is the best to do. You can take water in the morning, but don't eat anything. So, and by definition, you have to take that blood within 8 to 10 hours. By the time you go, you submit your blood sample after 12 hours, we call it, that's starvation sugar actually, because you have starved yourself past the defined hours. So if you had your last meal at 10 in the night, you should endeavor to give your blood sample by 8 to 9 in the morning. If you go by 10, you will just narrowly escape. If you go by 11, to be a starvation sugar. So it's most convenient to do because patients are taught how to check the blood sugar themselves. So it's very easy to do. But occasionally, we have to go beyond that. We have to do what is called 2-hour postprandial. We take our blood sugar in the morning, we determine the level of sugar, and we give you 75 grams of sugar or food or tea. We quantify because we want about 75 grams. And 2 hours we take the blood and test for sugar again. People who are diabetic tend to have a derailed or abnormal 2-hour postprandial sugar, and that's by definition. So I think I mentioned some of the normal ones. If you check your blood sugar in the morning, the first one is about 100 to 120 is normal in the majority of cases. But there is something that I discovered that most diabetics don't know. One will say, I have taken my blood sugar and it's 5.6. One will say, I have taken my blood sugar at 7 or 8. So they consider 8 to be abnormal. Please check on the strips. It's written there. Most people don't know. It's written in milligrams per deciliter and it's written in millimoles per deciliter. So a sugar of 10 milligram, which is about 5.6, is normal. Down to about, say, 7.5, they're still normal. One touch, people who use one touch, is actually 7.5 to 10.5 millimoles, still normal. And the other mistake most people make, especially those who are on the oral hypoglycemic or insulin, they check the sugar in the morning, it's normal, and they still take drugs. What are you treating? Your sugar is normal, so all you need to do is take your breakfast and go to work. In the afternoon, you go on eating your food, but put in your mind that you didn't take your medication in the morning, so it's likely to be going up now. So by the time you come for dinner, check the sugar. If it's high, eat your dinner and take your medication. So you have to be experimenting with foods. You have taken maybe a bar at night or pounded them at night or whatever. You check your blood sugar in the morning and it's high. Please recall what you ate the previous night. So that the next night, take something different and check the blood sugar in the morning. The last day it was high, it must have been because of that. So you have to because end of the day, we want you to own the management yourself. We want you to manage yourself. We don't want to be sitting in the consult room most of the time, maybe once or twice in a month. So that you end of the day, you own it. You know what to take to increase your sugar level. You know what to take to make it low. So a random sugar is about 200 in most clinics. We accept 200 milligrams per deciliter for random sugar as normal. This may not be for evaluating the result, evaluating the reliability. What was this for us? Now, what are the complications of diabetes? I mentioned that earlier. Heart disease, stroke, kidney disease, eye problems and blindness, dental problems, nerve damage, that's peripheral neuropathy. You have tingling at the tip of the fingers and the toes. We call it gloves and stockings. Gloves for the hands, stockings for the feet. So by the time you start having this tingling, it means your sugar is not controlled. You have poor control. And end of the day, you will have nerve damage if you are not careful. The nerve damages are seen commonly at the end organs. A kidney is an end organ because after the kidney, there is nothing beyond that. The eye is an end organ. After the eye, there is nothing outside it. The reproductive systems, in particular in men, they have erectile dysfunction because after the penis, there is nothing after that. So the small nerves are destroyed by hypoglycemia, poor control of diabetes. At the initial stage, you get an erection, but you cannot sustain it. With time, you cannot even have an erection at all. In females, they lose libido completely, no desire at all, because of dryness, because of pain, and on and on. So it's important for one to, because sometimes it can be the first manifestation of diabetes. It can be the first manifestation, loss of interest, dryness, painful dyspareunia, erectile dysfunction, and so on. Occasionally, it is a dental carie. You have a toothache that has been persistent, or you keep on having holes in your teeth, and you have what is called periodontitis. So your dentist will not pick that, and he may suggest that just go and check for sugar. We see a lot of diabetes with this kind of problem. So this is just to mention but a few. So how do you manage diabetes? I think I will just tell you basic thing to do. The most important thing to do is that you recognize the symptoms. You take your medication. You check your diet. Look at what you eat. Diabetes is never caused by taking too much sugar. Diabetes is never caused by taking sugary things. If you take a mudu of sugar, your urine will be sweet, and you will pass the excess, because your insulin will do its own, and your kidney will take care of that. You will excrete it out. You won't be diabetic. Diabetes is insulin deficiency or absence, not taking sugar. So please mark that. What you eat as a diabetic can worsen your condition. So that's why diet comes in. So you have to titrate. You have to balance medication, your weight, that's your lifestyle, and medication. Medication, lifestyle, and drugs. These are the three things: drugs, medication, lifestyle. I can understand that most of you tend to work sitting for many hours. Please create time, at least 30 minutes in a day, and do something. And don't sit for more than 2 hours without stretching out, walking around the house, because number one, if you are obese, you are likely going to have deep venous thrombosis. You can have a clot. And it's common among diabetes. Very, very common indeed. It happened to my own mother, of blessed memory. So please, don't sit down for long if you are obese or if you have diabetes. Walk around. It will help. And watch your medications. If you are not doing well on your medication, please report. Some drugs can do for one person and may not work for the other person. And I know that most of you will not be dependent on insulin, except if the sugar is so high and it's used for just a period of time to bring it down. Most of you will be on oral hypoglycemic agents, I believe. So this is for the type of foods. Time will not permit me to go through what we call glycemic index. Nigerian foods have been given a number. Sugar, pure sugar is 100. Down to pounded yam, eba, amala, rice, plantain, and so we give them what we call glycemic index. Glycemic index is telling you that this food doesn't have much sugar, or it's not processed. Processed foods generally have high glycemic index. Unprocessed foods tend to have low glycemic, and they're better. Like gari is good. If you process it, it's bad. Yam is good. If you go to the shop and take pounded gari that you make pounded yam, it may not be good because you have removed most of the fiber, and you need fiber. Foods that have high glycemic index are slower to digest. And because they are slower to digest, they feed you with sugar in quantum. It doesn't spike the sugar. If you take Fanta, it doesn't require any enzyme. It will go direct into your bloodstream. If you take Coca-Cola, it's sugar and water you took. It goes directly because it doesn't go through processes. If you take pounded yam or you take eba or any of the tubers, it has to go through enzymic reaction to digest from sugar to vitamins to this and that. The other one that are refined, they don't have to go through that process. So it's good to take high fiber diet. It's good for diabetics. And most of the Nigerian foods are good for us, but we don't know. We prefer buying from the shops. Sweet potato is better than Irish potato in terms of glycemic control, glycemic index. So I mentioned quite a few of them, but we can just go. Fruits are very good. Almost all fruits are good. Garlic, unsweetened yogurt, avocados, eggs, Nigerian foods. So in conclusion, eating a healthy diet, a well-balanced diet is the key. Added with that, your medication, and physical activity. If you take these three things home, I think the purpose of this presentation has been achieved. Diet, your drugs, and physical activity. You balance them. It's not easy. It's not easy at all, I know. It's just like it's not easy to lose weight. It's easier to gain weight. So, but you have to try and strike a balance. It's all about balancing the three things. So, maintaining a healthy body weight and losing weight if you are obese. Eat small portions, do not skip meals. Managing or reducing stress is very, very important because stress drains you. You say you find that you don't jog, for example, but sitting down to write judgment, to write books, I say you write books every night as a joke, because you write 100 pages, 200 pages, that's more than most of the average books actually. So if you do that, it drains you mentally, and the mental derailment is actually a way of losing sugar, but not muscle mass. You don't lose muscles, you don't lose fat, you lose the sugar that is within you only. Yes, but the stress is there. And stress is not good for diabetic, nor is it good for hypertensive. So I think the bottom line is, in order to maintain a current weight, you have to get your BMI. It's not accurate, but it's an average way of, it's an idea of what. So your current weight, if your current weight is good, maintain it. If you are half weight, lose it through physical exercise, and then burn the rest through other means. So you have to balance. Stay alive, be healthy, and be happy. These are the three things in life. You have to be alive. If you're alive, you have to be healthy. If you're healthy, you have to be happy. So there is no point you are alive, you are not healthy. And there's no point you are alive, you are healthy, and you're not happy. So do the three things. Try to balance them. Thank you very much. So do we go on to prostate cancer or breast cancer, and then later on we'll take questions? Which one do we do? Mr. Chairman. Okay, so the next paper, please. The next paper, please. Okay. No. Which one is that? Are we there? Okay, so let's start with, let's go on to prostate cancer. So the format may not be followed strictly. The definition of prostate, it's a small gland that is behind or just below the bladder. It is sandwiched between the bladder and the rectum. So that's the place. It's a rubbery gland, about ping pong ball, and it's deep inside the groin. The female counterpart is called Skin's glands. Most people don't know that the women also have prostate gland, but it's called Skin's glands, and it's the same position. Most people define it as they call is it G spot or G point? That's the way they call it. Is it G spot or G point? I think it's a language they put. So it's called, it's discovered 1950, this glands, just 1950, by a gentleman called Albert Grafenberg. This gland produces the same PSA that the male prostate produces, and they also secrete during female orgasm. So they are the male counterpart. The prostate is important for reproduction, and it's one of the organs that supplies a secretion that is contained in the semen. About 33% of the secretions of the semen is from the prostate gland. The secretion is slightly acidic, but with the rest of the secretions, the ejaculate is alkaline. It is divided into two lobes and a middle portion where the urethra passes. So most of the complaint that people make when they have prostate enlargement or prostate cancer is urine, but it is by no means the end. They can have cancer without knowing. the cancer of the prostate or enlargement of the prostate comes to their knowledge if they cannot pass urine only. What if the cancer is in the one of the lateral lobes, one on the left or one on the right? They will not know. And most of the cancers start from the back part of the gland. So that's why some people don't know they have the cancer until it has spread. So it is important to be checking your PSA, at least it's the only gland that we know, once in a year. It doesn't grow very fast. A prostate cancer, for it to metastasize, for it to spread, takes an average of 5 to 8 years. So you can see somebody with metastatic prostate cancer must have been having it for 5 years without him knowing. Yes. So this is the anatomy. That greenish thing is the prostate. The upper part where you see something passing is the bladder, and the red part that curves at the back is the rectum. So that is where the prostate cancer starts. This is not important. The prostate is the most common cancer in male, actually, worldwide. Although I heard that in the US it is the skin cancer, but here in Nigeria the commonest cancer in males is the cancer of the prostate. And you can see the cancer of the prostate in that picture on the right side, the lower one on the right side, in yellow. That is where the prostate cancer starts. You can see the middle part is the urethra. So that's where the urine passes. The upper part is the bladder. So somebody can have the prostate cancer lying down there for about a year or two, what we call intracapsular prostatic cancer and carcinoma or cancer. Can stay there for 2-3 years without you knowing, unless if you do PSA and it's going up. So it can remain confined in the prostate, what is called intracapsular, for some time. It may not cause any symptoms, and it can remain there dormant for years. However, while some type of prostate cancer may grow slowly, there are some that we know that can be very, very, that can grow rapidly. So we have to keep that in mind. African Americans or Negroes, they have the highest number of cases in the world. So we cannot escape that. It's commoner among the black race. West Africa is the 5th in terms of risk factors and incidence or prevalence in the world. But we are lucky. Our risk factors are not much. Even though we are blacks, if you move to America as a black, as a Nigerian, you are likely to get cancer there than to get it here, because there is a geographical influence also, the environmental influence. We know that Asians who are living in America tend to have cancer than when they are in Asia. So nobody knows why, but I think the environment has to do that. So if the reason why, if you have intracapsular prostatic cancer, that's a localized one or a regional one, it has not spread to the bones, to the liver and the rest, you have about 100% chances of it being cured. So you can see the importance of knowing, picking it early. But by the time it has gone far and wide, it has metastasized, you have only 31%, which is just 1/3 of what you should have. These are the types of prostate cancer that we see commonly. The Asna type. The Asna type actually is from the glandular part, the secretory part of the prostate. And it's the most common type of prostate cancer. It's written there. Ductal carcinoma is the most lethal. It is quite aggressive. Even though the first one, Asna, is commoner, is not as aggressive as the ductal type. And by the time somebody has a ductal type, we know that we have to be very aggressive in the management, more than if he has an Asna type. Transitional type is in the urethra, very close to the opening. I'm imagining one that I opened not quite long ago. It's very close to that, and sometimes it comes with obstruction of urine, actually, because it's near the urethra, the passage where the passage of the urine. Squamous cell is also very devastating. It quickly spreads as well. But this comes from the flattened cells of the gland. So what are the causes? The causes of prostate cancer is not known. The actual cause is not known. Nobody can tell you that. But there are things that can predispose to the development of prostate cancer. We call them risk factors. So scientists are still trying to know what is the actual pathology, what actually goes wrong. Well, there are quite a lot of papers presented, and they are very reputable and very educative. It is a mutation generally, which means the actual problem starts from within the cells, from the DNA in the cells. That is a mutation. That is a mistake in duplication. Now, these mistakes happen all the time. The skin that I have is not the skin I'm born with. I shed, I replace. I shed, I replace. The same thing in my brain, the same thing my liver, my kidneys. So when you had mutation, which means there is a mistake in this duplication, God has created what we call tumor suppressor genes. These tumor suppressor genes, they kill cells when they reach their lifespan. They kill them. And if there is a mistake in the duplication of the DNA, the gene, they repair. And they control the division. So something happens that suppresses these tumor suppressor cells. Tumor suppressor cells, yes. So by the time they are suppressed, the other opponents, they call oncogenes, they thrive. So there's rapid development, rapid replication, and then the tumor becomes a mass. So that is the genesis. That's, in a nutshell, what happens in the prostate. And even in the breast too. We'll come to that. So I mentioned that it's a malformation within the genes. And all other cases actually are from the DNA. So genes that have the cell, the oncogenes, the tumor suppressor genes, they are there on the slide. So that's what happens. Some are turned off, some are turned off. So on and off like that. It is also known, this is the second research, that you can inherit it. Even though we know DNA mistakes, by suppressing tumor suppressor genes, tumor oncogenes will not make you to develop cancer. But besides that, the other pathway is inheritance. You inherit a gene that will predispose you to developing prostate cancer. And one of those genes is existing in us in Nigeria here is the BRCA gene. BRCA gene is known to be a big risk factor in the development of the breast cancer and the prostate cancer. This cancer, this gene, is number one in Nigeria actually. So these are other genes that exist elsewhere. You can acquire that. Acquiring cancer is well known. If you are exposed to radiation, heavy dose of radiation, people working in radioactive plants, they tend to develop cancer because they are exposed to radiations. So, and by the time you are exposed to radiation, your DNA will be damaged more frequently than somebody who's not working under radiation environment. So they have tendency to develop that. There are certain cancers also that are not developed in people who work at the fire service, also people who work with asbestos factory, also people who work at the place where they produce car batteries, also people who work at which other factory again? Dye factory. This dye they do with cloth. So there are chemicals there that predispose that they are carcinogens. So we get that. Of course, we know also that are things we eat that are carcinogenic. There are things we smoke that are carcinogenic. So they can all predispose us to cancer. So acquired mutation is when you are exposed to all those things. Viral sometimes, chemicals, radiation, and so on. So these are the acquired ones. So the risk factors that are associated with the prostate cancer, anything that raises your risk is a risk factor. So different risk factors are there. I've mentioned quite a number of them. But why is it commoner in males than in females? Why is it that only 0.003% of prostate cancer in court is seen in women, and 99.99% of prostate cancer in males? Yeah, because age is a factor. Prostate cancer starts from the age of 50, and it's 6 in 10 actually in older men than 65. 6 in 10 of cases are over 65 years old. Race, we say, is commoner among the black race. Prostate cancer is in Asian Americans, I mentioned that. Geographical location, if you are in an urbanization actually, and I think the food we eat is quite a complex interplay of so many things, environment, what we eat, processed or non-processed, smoke, radiation, and so on. And then, of course, lifestyle. Lifestyle is important because there are lifestyles that you can avoid. You can't run away from having a family history, for example. You cannot run away from being a man. You can't run away from being a male or a female to develop breast cancer. But if you smoke or you abuse alcohol, you can avoid that. Those are risk factors that you can avoid. So the others, you just have to live with them, and you have to be checking. So I mentioned family history, genetic. If you have BRCA gene within the family, you are likely going to have that. Obesity, smoking can cause inflammation of the prostate. If you have sexually transmitted diseases frequently, you know, you have prostatitis, so you are frequently infecting the prostate, so the cells can now get tired and start misbehaving. So by the time they start misbehaving, a mass will grow, obliterate the prostate, and then you will have problem. So frequent ejaculation is known to reduce prostate cancer. This may be a good news maybe to some of our colleagues. So the more frequent you ejaculate, the less you are likely to have prostate cancer. But it's laughing there. So how do you know you have symptoms? How do you know you have prostate cancer? Prostate cancer is difficult to diagnose really. Two things are very important. You have to check your PSA once in a year, and if you have any of this, see a doctor for what you call DRE. DRE means digital rectal examination. Why? It's very uncomfortable to stick a finger into the back passage. It's very uncomfortable, we know. But in the case of the prostate, you can pick a cancer without even PSA, without even MRI, without even doing any scanning, because the prostate can be felt in the rectum. If it is cancerous, it is hard as a wood. If it is cancerous, the mucosa near it will be fixed, and it will not be mobile, it will not be smooth. You will feel it. So by the time you have that, I can tell you have over 90% of the diagnosis in your hand. The rest, PSA will tell you. So if you have PSA, you do digital rectal examination, you can clinch 98% of the diagnosis of prostate cancer. So others are throbbing pain, weak dribbling urine, discharging blood, difficulty having erection, decrease in the amount of ejaculate, painful ejaculation, so many and so on and so forth. But this is not specific to prostate cancer. Let me be clear with that. You can have a benign hypertrophy, you can have a prostatic inflammation from bacteria, you can have other things that can manifest this way. So if you have any of these symptoms, do PSA. If it is very high, see your doctor for that. If you don't want to do digital rectal examination, MRI is a substitute, and you cannot beat MRI after DRE. So this is not so relevant. That's the classification, the staging. Staging is good when you come to managing the case, when you come to treat. Because if you have T2 to A to T2C, is two more, that 2 is giving a name, the size. C is whether it has a little move, it has moved outside the lobe or not. But what I want to emphasize here, from T2A, which is the first stage, to T2C, you can take up to 3 years from that to that level. So you can see that if you have T2A, you can quickly, if you have the symptom, just check. It takes nothing. We do PSA outside, and it's 15-20 minutes. We get a result. As simple as that. So, but another thing is that if you have it within the prostate gland, I can assure you, you will live in the next 5 to 10 years 100%. So you can imagine you have bought plenty of time, because within 10 years you can map the type of treatment you want. The treatment has actually been evolved, and it's not very cumbersome now. It's more readily accepted by most men. Time has passed when we do orchidectomy, we remove the testes. No, we don't do that anymore. We do medical orchidectomy. And medical orchidectomy is very much available and it's cheap. It's not that expensive. Or like breast, we have to think of so many things. Psychologically, the man may take it more than a woman losing her breast, for example. It's better to lose a prostate than to lose a breast, as far as I'm concerned, because I know what a woman can go through with one side of the breast removed, even though if she puts something, psychologically there is a problem. So you can remove the prostate medically, your testes are there, but you have taken them off medically. So how do you prevent that? Prevention of prostate cancer is not a big deal, really. If you do this, what I'm going to say any moment from now. So say no. Actual inactivity is the most important factor. Lack of exercise is the most important factor in the development of prostate, because we know that stress triggers suppression of tumor suppressor genes. The genes I mentioned that when they are switched off, then the oncogenes will now start developing and make the cancer to grow. So if you do exercise regularly and you maintain weight, believe me, you are not likely going to have prostate cancer. But if you have a family history and you have inactivity, you have better chance of getting the cancer. So it's much easier to really manage or to really pick. Do PSA every year. If you have a doubt, do MRI or see a consultant to do DRE on you. He will tell you, I can tell you 98% of the problem can be picked. So it's as simple as that. It's better than to tell you that than even reading the slide. I think I mentioned that here. You can see DRE there, 50 years and above. So you do PSA and you do DRE. So it will suffix. But if you don't want DRE, you can do MRI. For women, they can do BRCA, but I don't think it's necessary. You can do BRCA for breast cancer, which we are going to talk about shortly. So early detection is the key. Report urinary symptoms as soon as possible. Annual PSA screening test if you are above 50 years. Lead a healthy lifestyle and diet. Avoid using tight underwear. Yeah, because I told you firefighters are prone, radiation prone. So if you are heat, actually is an enemy to spermatogenesis. Not even prostate cancer, even to production of sperm. You can have an empty semen if you, the type who wears tight underwear, because the testes are outside the body simply because heat is an enemy, and you can develop testicular cancer even if you have a tight underwear, you don't ventilate. Thank you very much. Next slide.
Thank you.
Thank you.
The third paper, please.
The third paper, please. Okay. Sorry. So the anatomy of the breast, let's start from that. We are not going to follow the format again. It is circular or globular in shape, but it can be pendulous as age advances when you look at the structure. It is broadly composed of the skin, the areola, which is the darker part, and the nipple at the center. Those are the outer things. The inner one is called stroma, and the stroma is divided into two, intralobular and interlobular. The interlobular are the connective tissue structure, the fat, the tubes, the small muscles there at the nipple. Those are the things that give the breast the size and the shape and the support. The intralobular are the functional unit, the factory, the milk factory. Those are the lobular, and there are 15 to 20 averagely in a breast, in a female breast. So these are the anatomy. You can see the alveoli is where the milk is produced. Then it passes into the alveolar sinuses through lactiferous duct, and the milk is stored in the sinuses. Those red things are called myoepithelial muscles. And these are the things that contract to eject the muscles during suckling. This is important because breast cancer spread faster or commonest through the lymph nodes. There are only 3 where breast cancer spreads to. Into the axilla, that's the armpit, under the breast, under the muscles on which the breast rests, is called subareolar, and then that is substernal. Substernal are within the chest, so we don't hardly see them. We don't see them actually. So this is what I mentioned, lymphatic drainage. Yeah, it is the cancer that is dreaded, that concerns women. It is not the only one, but the one most feared actually. We have ovarian cancer, we have cancer of the cervix, but they are not as common as breast cancer. And they are not as devastating as breast cancer. When I come across a young lady with breast cancer, I feel like shedding tears because they come late. They don't know they even have it because it can be mistaken with so many things. So it occurs in women, in both men and women. We have male who come with breast cancer, and it is very aggressive in them because there is no tissue to slow the transmission, the spread. It's just skin, muscles, and bone. And beside lymph nodes, breast cancer goes to the bone, then to the liver, then to the brain. So you can see how the damage can be caused. So by the time it reaches the liver, it's actually late. In Nigeria, breast cancer is the commonest, and you see even in the under 30s. I've seen one in 25-year-old. So that is very sad, and it's fungating, offensive, and it has spread very far indeed. So it's good to know. It's good to know breast cancer because we are seeing it very, very commonly. We are seeing it very frequently, and in younger women who are 25, 27, 30. So we used to see that in the 40s and 50s, but now it is not. So things have changed. I think maybe because of diet and the environment. Invasive ductal carcinoma is the commonest, and it's aggressive, unfortunately. It starts from the ducts. Most of the cancers in Nigeria, breast cancer in Nigeria, are attributed or they have relationship with one of these genes, in particular BRCA1 and 2. Forget about the rest, PAV2, ATM, and the rest of them. BRCA1 and BRCA2 are the commonest inherited breast cancer among Nigerian women. In fact, not only breast cancer, even ovarian cancer is related to BRCA1 and BRCA2 genes. So you can see that if you can check your BRCA1, BRCA2 every year once, then you are checking both your risk to developing breast cancer and your risk to developing ovarian cancer at the same time. So we see them 30 to 40. Commonly, 95% of them are among the parous women. Parous means they are in the childbearing age, because that age, 31 to 40, is still childbearing. So that's why I say parous. The remaining 60% were in premenopausal. Premenopausal is a definition actually. There's no specific, because you can see a woman having her menses after the age of 52, 53. And once you can see another one that has finished her menses at the age of 45, 46. So it depends. So, but generally, we see them in the younger age group these days. So knowledge of the breast cancer manifestation in the population is very low in Nigeria. Many women know breast lump, and it stops there. But there are other manifestations that they don't even know about. And that's why we see them late. And when we see them late, we feel sad. We feel very sad indeed. I feel very sad, sincerely, when I see them coming late, because they don't know. It's not their fault. So it's good, I think, to educate them right from school. Right from school. A young girl having that is a big problem, not only to herself, even to the family. So I think they better put this in the school curriculum so that they know. Yeah. So other symptoms are not even well known. So unfortunately in Nigeria there are 14 cancer treatment centers, only in 10 states out of the 36 states. And as of the last 2 months or so ago, I know that only 4 centers, sadly, only 4, they have radiation centers. They offer radiation therapy. Most of them do chemotherapy. And the chemotherapy, sincerely, cannot be the only option because it's devastating. You see a woman under chemo, you feel like crying for her because it's devastating. It's worse. In fact, some of them run away from. They don't complete the chemo. So in one study here in Lagos, 64% of patients know that breast lump is a symptom. But they report even 6 months after, even though they know they have a lump. Because some think that lump will disappear. Why? Because it's painless. Pain brings patient to the hospital. 90% of the patients we see come to us because of pain. So you have a lump and it's painless, so you don't bother. My sister died of breast cancer. She had a lump for 3 years. When I said, why didn't you tell me? She said, it never pained me. Simple. And she died of it, unfortunately. So another reason why they come late, or we see that, is because the treatment is very costly here in Nigeria, I think even worldwide, because the average chemotherapy in Nigeria is over $2,000. So not many people can afford that, actually. So general symptoms are that you have changes in the breast outside. If there are changes, so you have to look at this. I have slides that will teach you or will show you how to do your self-examination. You do what you call breast self-examination on your own. So I'm going to take quite some time to show you those slides because they are important. It's good to pick it. But before we reach that, if you had change in the size or shape, or change in size or shape of your nipple, please see your doctor. If you have a discharge from the nipple, especially bloody discharge, please see your doctor. If you have pain, it may be an abscess, but we know one type of cancer, only one, that presents with pain. That's an inflammatory breast cancer. Still see your doctor. If you have redness, see your doctor. If you feel a lump, some are very good in picking a lump, please tell your doctor, especially if it's painless. So this is a picture of inversion of the nipple. The nipple goes in. This is an animal sign because something is behind that inversion. You can see the other one, that picture there, is an inflammation. The inflammation, you find the skin of the breast like the skin of an orange. It means if it has pain, we'll be happier. We'll be even glad. We can even celebrate. But if it's painless and the skin looks like the skin of an orange, you can see the right breast on that picture. It's painless and you have this. Oh no. It's likely going to be a cancer behind that. So, how does it start? They start from abnormal growth of cells. And this is important. Why? Because when the cells grow fast, they tend to form a lump. And that's what we call breast lump, and that's what you feel. It's unlike other cancers that do not grow rapidly and produce a lump, result into a lump that cannot be picked. Like the cervix, for example, you don't have a lump there. So, and like I told you in the other slide, it's actually as a result of a mistake in the division, cell division, genetic division, DNA division within the cell. So mistakes are not repaired by tumor suppressor genes, and because that mistake is there, they tend to produce abnormal cells. And abnormal cells are not recognized by the oncogenes. In fact, even if you have some remaining tumor suppressor genes, they cannot record, they cannot recognize. The signal is not the same. So they allow them to go. So most likely breast cancer is caused by a complex of interaction of so many things. Environment, hereditary chemicals, some drugs, so radiation, and so many other things. So it's a complex thing. But we can now understand our own. If we have the history, let us know we have the history. If we can examine ourselves and see an abnormality, we report early, because when you report early, it's much better, it's much easier to manage. So I mentioned all that. There is another gene that is called HER2. HER2 is called Human Epidermal Growth Factor Receptor 2. This is not a genetic predisposer, but it promotes cell growth. So if you have that and you have a lump, it's likely going to be much bigger. Even if it's a benign lump, it can grow faster because you have that. So the disadvantage we have in Nigeria from certain studies that we did is that most of those, I told you, is invasive ductal carcinoma that the commonest, and that is aggressive. Why? Because 95% of this invasive ductal carcinoma that we see in the younger age group in Nigeria, they are triple negative. Triple negative, let me see how I explain. If you have a room and you have cancer inside that room, and there are 3 locks to that room: estrogen, progesterone, and HER. Estrogen, progesterone, HER. Any key you use, you can open and kill the cancer because they will recognize the key. In triple negative breast cancer, estrogen is negative, progesterone is negative, and HER2 is negative. So which key do you have used to open? You don't have any key. Fortunately, chemotherapy works. But if you have estrogen receptor positive, oh my God, progesterone receptor positive, oh, that's good. I'm managing my direct junior sister, same father, same mother, for breast cancer right now in the last 2 years, and her breasts are normal. The lump is gone, and she is okay. I'm managing my cousin also on that because they are all positive. If you have estrogen receptor positive breast cancer, all you need to do is to take anti-estrogen. If you take anti-estrogen, it blocks the estrogen, and the cancer will not be able to use estrogen to feed and grow fat. I hope you understand the difference. So it's better to check. Is it estrogen receptor positive? Yes, fine. Is it negative? Then remove it completely. I conserve their breasts, and they are there. One is about 3 years, the other is 2 years, and I'm managing them. And the drug is cheap. It's about 1,000 naira for a whole month. So you can see that if you have that, there are ways you can solve the problem rather than going through chemo. So invasive ductal, I told you the commonest. We have lobar carcinoma in situ. We see lobar carcinoma in situ, but the problem with lobar carcinoma in situ is that we don't classify it really as cancer per se, but if it becomes carcinoma, it becomes bigger, then we consider it. It's difficult to pick because it's within the factory where milk is produced. So it's difficult to pick. It doesn't form lump. It doesn't form a mass for one to pill. So how do you pick it? Even mammogram doesn't pick it. Even mammogram doesn't pick lobar carcinoma. So, but if it grows out, it becomes invasive, then maybe. But it's important to know that you have an abnormality. Good thing about it that you can know from the skin changes. You can have focking, scaling, discharge from the nipple because you know it's from the factory, I told you. So chances are that the discharge coming, if you squeeze the nipple a little bit, it may be bloody, and then you know. Because in fact, even if it's not, it will tell you that you have a papilloma there, and they are the same story. So you can pick it. There is other ways. So it's important for you to know how to examine your breast. Very, very important. So you can see it there in that's lobar. You can see it's within the duct. So how can you pick that? It's difficult. Paget's disease, well, it used to be classified as a disease, but we know now it's precancerous. In fact, it's cancer. When I was in London, we see faggots and we say just cancer. We treat as cancer. Faggot is a gentleman from St. Bartholomew's Hospital. He discovered so many things in his life, including breast cancer. He has a bone cancer named after him. He had other things named after him. He's a very seasoned European. If you are 50 years and above, you are likely going to, and you have a bloody discharge, you are likely going to have cancer of the breast. If you have DCIS, it can transform into ductal cancer. So it's the earlier you pick, the better. Bloody discharge is not good. We have angiosarcoma and sarcoma. Sarcomas are rare. I've seen only one in 40, 50 years. So recurrent cancer is devastating because if you have breast cancer, they diagnose you now, initial diagnosis, you take it. But you are treated and now they tell you after some that it has come back. So you can imagine that can be even more devastating, I think, than the original diagnosis. But the good thing is that we tend to be very aggressive this time around. We tend to do everything. We give radiation, we give chemo, and we do palliative. So in order to make sure that everything is off. Why? We could have given anti-estrogen, but most of them, I told you, they are estrogen negative. Investigation, these are important. You can do and that's a CBE, clinical breast examination by a doctor. Mammography is not very important. I have no much respect for it really, because if you have fibrous breast, it can show a dense area, and the doctor or the radiologist will tell you, this is a suspicious area, and destabilize you. So I think if one wants to really do something that will make her to have a rest of mind, go directly to do MRI. Simple. It will tell you everything. But what I prefer, I personally, this is my opinion, is to do an excision biopsy. That's about number 6 there. Because when you excise the mass, you take it for histology, they will tell you it's cancer and even the type of cancer. And even the type of cancer, because estrogen positive or negative, you will still know from that small tissue that you remove. So you can just start treatment immediately without having to wait. And it's not expensive actually. We stage the cancer using TNM, that's TNM. TNM is tumor, lymph node, and the metastasis or no metastasis. So M is only 0, either it has spread, 1, it hasn't spread, 0. Tumor, T, is stage 1, stage 2, stage 3, stage 4. That depends on the size. Lymph node is, have they reached the axilla? Have they not reached the axilla? So we give them grade. This is to help us in the management. So the risk factor is if you are a woman, you have risk more than being a man. Increasing age, family history of breast cancer. Yeah, it's good to know that if you have a sister or a daughter with breast cancer, you are more likely to have it than if it's your mother. This is a study done. The same thing with the prostate cancer. If the father has prostate cancer, you may not get it. But if your brother has, you're likely going to have it. Yes. So history of cancer of the breast in the family, or history of having a cancer in one breast, you are likely going to have it in the other breast. Or if you have history of repeated problems within one breast, you have to be very careful. So most of our patients that have fear, they come repeatedly with discharges, no problems, I told you, there's nothing. No, I want to give her a relaxation of mind. So I say take anti-estrogen, in particular if you have completed your family. I have one bad patient that I'm still not happy with her. She had cancer, we know. We did everything for her. We say, okay, you have a child or two, stop. She went and got pregnant. And it was estrogen positive. So she added estrogen because of the pregnancy. And it spread like wildfire. So sad. So if you have the inherited gene, that's BRCA1 or 2, if you have HER positive, but I mentioned that HER is not a gene that predisposes to cancer. But if you have that, it makes the cancer to go wild because it promotes growth of cancer cells. If you work in irradiation or exposed to radiation in childhood, you are likely going to have that. Obesity is a predisposing factor. Early menarche, you have the menses at the age of 11 or 12, you are likely going to have, it's a non-precursor actually. If you began your menses at an older age, 2, or you reach advanced age before you reach menopause, you are likely also going to have breast cancer. If you have your first child over the age of 30, you are likely going to have, it's a risk factor. If you are on hormone replacement therapy because of menopausal syndrome, you are likely going to have breast cancer or endometrial cancer. So it's better, I think, to take the smallest dose if you are having problem with sleep disturbance, appetite, mood changes, all those things that are related to menopause. So we take the smallest dose, but we have newer drugs now that contain 0.003 milligram of levofloxacin, and so you can just take that. So, or you have to take it, if you have to take it. If you abuse alcohol, please drop it. It increases also in women. So, breastfeeding, these are the prevention. Breastfeeding is known to be a factor in reducing greatly the risk of developing breast cancer. So it's quite important. So breastfeed for at least over a year. Early marriages, people, I'm not talking about 12, 13, but marry at the age of maybe around 18, 19, and then continue education. Have your children before you are 30, even before 25. I would advise before 25, have your children. In fact, you can complete your children by 25 so that you can do whatever you want to do with the rest of your life. So you have to be familiar with your breast, the size, the shape, and how it feels, because no two breasts are the same. Even the right breast is not the same as the left breast. I'm sure I'm right. So even the right is not the same with the left breast. The left breast is bigger than the right breast anyway. So learn to do BSE. If you have doubts when you are examining your breast, please see a physician to do CBE, that's clinical breast examination. But first of all, do breast self-examination, know how to do it. We are going to come to that. Try to do an exercise, even if it's for 30 minutes in a day. You can limit your hormone replacement therapy if you are having postmenopausal or premenopausal syndrome, sleepiness, disorder, mood changes, and so on, losing your temper easily, and so on. They all know them. So if you have that, please take the small dose to just alleviate it. Maintain a healthy weight. If you have a good weight, then maintain it. If you need to lose weight, first of all, you have to reduce the calories you eat, and then you can throw away the rest by burning them up. Choose a healthy diet. All these are vegetables, fruits, and the rest of them. They have what we call antioxidants, vitamin E and vitamin C. They prevent cancer, and this is a well-documented studies. In fact, it is a what they call randomized clinical trial done in several centers. If you take vitamin C or vitamin E, you are likely going to avoid cancer. Not only cancer of the breast, cancer of the prostate, cancer of the colon, cancer of the ovary. Those supplements are good, but know what you take, because there are a lot of junks in the market. They say this one is good just to get money. So go on pure vitamin E or vitamin C. So the first step in breast self-examination is that you please stand up in front of a mirror. So look for this side, your size, the shape, and the color, the skin color. Next, you look at it from each angle. You turn from side to side and lift them up. So you know what you see. You can see everything. So that next time when you see something different, you know that this wasn't there last time I checked. So these are the things you should observe. Furrowing, bulging, or dimpling. This first line, the third dot before dimpling, furrowing, is around the dark area and the nipple. You observe these ones around that area, the nipple and the areola. Nipple that has changed position or is gone in, please note that it's not a good one. Redness of the skin or soreness or rashes or calcification, jot it down. Number 2, now you can raise your hands up, because when you raise your hands up, the breast will also lift up. Now, see the symmetry. Is there any change in size? Number 3, step 3. While you are still at the mirror, squeeze the nipple a little bit to see if there is any discharge. There must be. I'm telling you, there must be a discharge. But what is the color? Is it watery? Is it milky? Is it pussy? Or is it bloody? So not that, but there must be a discharge. I'm not telling you this. Step 4, next, fill your breast while lying down. Because when you lie down, it also collapses. So, and there are now, you now have something at the back, which are the ribs. You have your rib cage. So, using your 3 fingers, the middle 3 fingers, the palmar side, you can go on around, choose the direction you want. You can start from the outer to the inner to the lower, then backwards. You can go round and round, or you can divide your breast into quadrants: upper, inner, upper, outer, lower, inner part, lower, outer part, then the center. So you can palpate them and feel for anything, a lump in particular, or pain. These are the only things you can feel. So you do that. For the right hand, you use the left hand. For the left breast, you use the right. You alternate. Using a firm, smooth touch. Some actually feel it better when the hand is wet and soapy. So they prefer to do it when they are taking their bath. And I think that's the best time to do it. Especially if you have a place where you can come back maybe to the room and do the lying down one. You can skip it. Because with time, you find that you can skip most of those parts, looking at the mirror and say you can just go for the lump. Yes. So take a pattern that will be easy for you. So step 5, this one, I mentioned that when the hand is wet and soapy, you do that. So you do that standing or sitting. So you cover the entire breastplate using the hand gentle movement as described before. So in conclusion, you have to raise awareness because it exists and is getting, is rising, in particular in our environment, in Nigeria. So we have to be aware, we have to teach the younger ones. We have to encourage early marriage, although this can be very difficult. Difficult in the sense that time has changed now, you know, and it's not like before. But we have to encourage breastfeeding, which is good. Every woman must learn how to do basic breast self-examination. Breast screening, if you are opportune, you have the means, do BRCA. So you know whether you have a family history. It can start from you. If you have a family history, then your daughters, your granddaughters, let them know. You have saved them that because they will tell you, oh, my grandmother, as if she's their granddaughter, or my mother, if she's their daughter. So it can start from you because you may not know what happened to your parents because this wasn't existing during their time. So it's good to do that. And if you are 50 and above, I think it's better for you to do that. So that at least you can pass that message. I have BRCA 1, BRCA 2 positive history. So let them know. So lifestyle also is good. If you are on HRT, reduce the dose, if at all. Thank you very much. So we can now take some questions.
Please come and sit. You are seated. Thank you. On behalf of the Honorable President and all of us, I want to say a very big thank you to Dr. Garba for very, very insightful presentations. I'm sure we're all more enlightened and better informed than when we came in. I'll now give room for questions. Please, I want to encourage us to not, for instance, if a question agitating your mind has been previously asked, there's no need to repeat. So, going to take about, let's say, 8 questions. Let's see how far we can go with 8 questions. And doctor, please, can you note the questions so that then you answer at the end of all the questions.
Yes, doctor. Now this BRCA1 and BRCA2, does it mean that when you have BRCA1 or BRCA2, that you are most likely to have breast cancer? That's number 1. 2, it is becoming very worrisome that men also suffer from breast cancer. And we know that it is not very easy for men to go for mammogram. Do you now suggest that men should go for mammogram? Yes. How do they do it? Because they don't really have breast tissue like the women. We, the women, we know that it would be almost impossible for men to go for mammogram. How do they do it? Thank you.
Thank you very much.
Thank you, my Lord the Chairman. I wanted to find out from the doctor whether it is possible for him to give us the copies of what he had just delivered.
Okay. Copies.
Sorry?
Yeah, I'm going to give the ICT.
Please, we need the copies.
They can make copies.
Okay, thank you.
Yeah.
All right. The question.
They will make copies.
I can't hear
Questions
you.
will be, papers will
I've
be made
given them the slides, so they
available.
are going to make copies.
Hard copies.
The ICT.
All right. Then the next one is that you talked about discharge from the nipples. What could give rise to blood discharge from the nipples?
Okay.
Yeah, because somebody had it, and it was said that it was caused by dilation of the milk ducts. So I want to know what actually could have given rise to that dilation of milk ducts.
To
Sorry?
what gives rise to what, please?
Sorry?
Your second question or your second statement.
I can't hear you.
Your second question.
The second question.
Again.
You made mention. You asked about nipple discharge, blood discharge from the nipple. What
Yes.
causes that?
Yes.
I caught that one. It's written. What? Your second question, please.
Yeah, that has to do with dilation of milk ducts. What could give rise to that as well?
Dilatation.
No, dilation.
Dilation.
Yes.
Of the brain. Of the
Dilation
milk
of milk ducts that
okay.
led to discharge of this substance from the nipples. Thank you.
Next question, please. My Lord Bolaji, yourself.
Sir, did you say vitamin C and E reduces chances of cancer or increases it? We didn't hear well.
My Lord Akimbami.
Thank you very much, Doctor, for the very enlightened papers. But my question is, what would you suggest to be the best method for women to find out if they have breast cancer? Is it the mammogram? Because you didn't appear to be very enthusiastic about mammogram. So I want to know which is the best method. Is it the MRI? Thank you, doctor.
Doctor, thank you so much for this wonderful lecture. On the inversion of breast, there are people who normally have inversion, is inverted nipples. Is it every inverted nipple, or is it when the nipple, after some time, becomes inverted? Is that when it's a problem, or that the person just has inverted nipples?
What about my lots in trousers? Oh, okay, as in trouser. Are you not worried about prostate cancer? Okay, thank you, my lord. Sorry, I can't see your face very well. Okay, my lord Ige.
Thank you very much, the chairman of the session. Doctor, we are very grateful for the most scintillating and most understanding lecture that you have delivered, because you so simplified it for us that many of us are very much satisfied that you are really in charge and you know what you are talking about. But you talk about radiation. Can we say that this is our mobile phone, which some of us put in the pocket and sleep off, or put at the head as like a pillow, can cause this radiation or attract prostate cancer or aggravate it? There are other radiation like a battery attached to the television and so on, all these plasma televisions and the rest. And most of the night, we leave the television on, and many of us even doze off or sleep off until 4 a.m. or 5 before you remember that the television is on. And you have the signal here and there, everything going all around you in the night. So one will want to know whether such thing can cause prostate cancer and how we can curb it. Thank you.
Okay. Doctor, I have a question, or maybe two questions. The first one is, you said that the female also has an equivalent of the prostate gland. Can this also get problematic? As in, can it go cancerous? And then, what does frequent urinary tract infection portend for sufferers? Urinary tract infection, especially for females. Those are my two questions.
Okay.
Okay, I'll now yield to Dr. Garba to answer the question.
Okay, thank you very much, Mr. Chairman. On the first question, BRCA1 and BRCA2, these are genes, inherited genes that can predispose one to development of breast cancer and other cancers. If you have BRCA history, or you are BRCA1, BRCA2 positive, it's not an automatic ticket to developing breast cancer. But you know you have that. Whatever you develop, whatever you see, you know you have that history. The same thing, people who are free of BRCA1, BRCA2 can develop cancer of the breast. because of other reasons. These ones are the ones we know. There are so many things that predisposes one to developing cancer that are not known yet. These ones are definitely known. You can get a risk factor from the environment if you lived abroad. Come back home, you don't know you have that risk factor, and it manifests there, and you are BRCA negative. But can they check ATM, FALB2, other markers? They can't. But to answer your question, that if you have BRCA1, BRCA2 positive, you have higher chance than somebody who is negative of developing breast cancer. Yes. The other thing you talk about mammogram in males. Mammogram is a procedure that is done even in females. I think they recommend the age of 50 and above. And even among the females, those who have fibrous brain that has a lot of internal stroma, the connective tissue. Because if you know the procedure, they put a plate under and a plate on top, and they compress. It's a very painful procedure. So in males, it's not possible. How do we diagnose in male? We take a biopsy. We pick a skin. We take a tissue and send to the lab if we have high index of suspicion. And that's the only way we can diagnose it. I don't believe in cytology because we don't have many cytologists in Nigeria, and I doubt quite a number of their results. I'm being honest with that. So they have to take it to about 3 or 4 of their colleagues to put it together. It's difficult, it's not a straightforward thing. But if you take a biopsy, they look under the microscope, they'll see cancer cells, and they know, they give it even the type. So it's good to do an excision biopsy. If you remember during the presentation, I said to do an excision biopsy is the best to me because it kills so many birds with one stone. I know the type of cancer, they have removed it. I know the ages because they will look at the ages. Have I removed the whole cancer out, nothing remaining? They will look at the age. If I have some remaining, is it estrogen positive or negative so that I know what to do next automatically? Have I answered your question, ma'am? Honorable Justice, have I answered your question? What is it that you are still doubting? You asked 2 questions about BRCA1 and 2, a mammogram, if I remember. The first question is about BRCA1, BRCA2 genes.
No.
Oh, that's you. Okay. So for your own, are you happy now? Okay. You asked about blood discharge from the nipple. And what causes that dilatation? We call it dilatation. You see, blood discharge from the nipple is from the duct. And the duct that is in the nipple area, not in the milk producing area. From histology, and from all the samples I've taken for histopathology, it is most of the time intraductal papilloma, not carcinoma. Carcinoma is the cancer. Papilloma is benign. But if it's there for many years, it can transform. So sometimes when you have nipple discharge, they do that. And that's Paget's disease. If you Paget's disease of the nipple, I mentioned it. So if they check the blood, they will see papilloma cells there. The report will come back. It's an intraductal papilloma. Shikena. I do something for that. There is a treatment for that. If they say it's intraductal carcinoma, because intraductal carcinoma can be intraductal carcinoma in situ, which means it hasn't spread. Or it can be intraductal carcinoma invasive. Then I will ask further question. Go ahead and do estrogen receptor for me. Then they will tell me it's negative or positive. Now I know I'm dealing with triple negative. So histopathology helps us a lot. We work hand in hand with them. So nipple discharge is from intraductal papilloma in most cases, but it can be from intraductal carcinoma, so we want to know. Now the other thing you mentioned about dilatation of the milk. I didn't quite get that question, but you know, the milk is produced in the alveoli. Alveoli are within the lobules. Each breast has about 15, 20 lobules. So in each lobule, we have alveoli. These alveoli are the factory. They are the production line. After producing, they are channeled into ducts. These ducts are called lactiferous ducts. So this lactiferous duct will now channel the breast milk into lactiferous sinuses. This is why they are stored. And when a breastfeeding mother has engorgement of the breast, it is the lactiferous ducts that are paining her because they are engorged. The moment the child suckles, it goes down. You know that. So this is where, and the myoepithelial muscles I mentioned are near those lactiferous sinuses. So the moment the baby catches the nipple near the circular area we call areola, that's where they are concentrated. A little suckling, now even if he removes his mouth, you find the milk coming out on its own because the muscles have been stimulated. So that's why they are stored. That's why they call dilatation. That's why they are called sinuses. Yes. Are you happy? Thank you. Okay. Now, vitamin E and C, they are called antioxidants. Antioxidants are known to be chemicals that kills cancer cells at infancy. And they can also make DNA to be livelier, to be younger, and they can make cells to avoid many mistakes. It's important to introduce supplement from the age of 50. Why? Because it is from that age that you go through a lot of stresses. Stresses of children, stress from the husband, stress from the wife, stress from work, stress from this, stress from that. So if you are on antioxidants, you are likely going to remain healthier because it is helping your natural immunity to fight some other things that you may not know. An example is that if you have catarrh, which we know is a viral infection, even corona, we know is a viral infection. You take vitamin C or vitamin E, symptoms tend to disappear. It's not by magic. We know what is happening. So they will not give you antiviral, but if you take vitamin C or vitamin E, and now there's an addition, zinc. So if you take that, it boosts your immunity. It makes you healthier, and it fights some of those small mistakes for you. Are we happy? Mm-hmm. Okay. So it's not that it increases cancer or decreases, but you can see in a way it's actually helping to delay the development of cancer or even to correct the mistake that would have resulted into cancer. Number 4, the best method for screening. Now, I think she mentioned mammogram. I have no respect for mammographic result because there are so many false positives and so many false negatives. They will only tell you this is a suspicious area, which means you have to go further. What do you mean by suspicious area? Suspicious positive or suspicious negative? Many a times, you go in to take that suspicious area, you won't even find it. So the best thing is for me, if you have something that I can feel with my own fingers, I go and take the biopsy there. That's what is called core biopsy, and they do that for even prostate. I don't believe in that, except if the mass is big. Because for the core biopsy to be successful, you have to pass your needle to go into that mass, into the middle of that mass, and pinch it out. Then you know you have taken part of it. But what if the cancerous cells are at the periphery? You can miss it. You can easily miss. I know people who have prostate cancer and the result came out negative because the biopsy did not pick where the cancer cells are. And they can only report what they see. And that's why they say, take the biopsy from 3 locations on the prostate. Why do I have to pinch you 3 times? You can do MRI. MRI is very sensitive and is specific, and it can take millimeters of something and analyze it. So just go for MRI straight. Yeah, and that's my opinion, that's my advice. Inverted nipple. We know nipples tend to start budding from the age maybe of 10, 11, or maybe earlier now because of good diet. But if your nipples, which means they are in, you know even from the age of 12, 13, 14, 15. And I have never seen any breast cancer at that age. So if by the time you're about 25, 30, and you want to do breast self-examination and you see it inverted, you report it as inverted because you know it has been you have been having it as inverted breast right from the word go. But if you know that last month you did this test, or what's happening to my nipple? It wasn't like this. You know it wasn't inverted before. Now you are discovering it's inverted. That's when you have to be suspicious and report. So it's not that you have inverted nipple and now you are seeing inverted and you report. You are not reporting anything. It won't make sense. It doesn't make sense anyway. Am I clear with that? Okay. Radiation is dose related. If you are working in a factory where they produce handsets, no, you won't have cancer because the radiation is small. For a radiation to cause cancer, 3 things must happen. The dose of that radiation, the time exposure, that's the period you are exposed to it, and then the portion that is exposed. You don't get cancer of the ear because you're answering telephone. Number 1, the radiation is not much. Number 2, you don't stay, even if you stay for 1 hour, it will not cause that, and you shed radiation. We know people shed radiation. People who work at the nuclear plants or radiology department, they have a tag, and they read that tag. End of the month, they go, they take the reading, and if the radiation level is a little bit high, they say go or leave, so that you go and shed the radiation. And we should not forget that even the food we eat has some radiation. Even the ground we march has some radiation. If you walk barefooted, you are taking some radiation and you are dispensing some. So it's not a radiation from the handset or TV that can cause cancer. No, the radiation in those kind of appliances is very, very minimal. It's very, very unlikely for it to cause cancer. But if you are working in a nuclear regulatory agency and there are so many things that they are exposed, they will tag you. In fact, they must tag you. Why? Because before those centers are established, there must be a regulatory body to go and supervise that place. They must make sure everything is there. They must have a lead lining. Any radiology department has a lead lining so that the radiation will not escape. And to add to it, radiation has a distance. And there are different types. Electromagnetic radiation do not travel fast, do not travel long distance. They attenuate. We call it attenuation. X-rays, gamma rays, they are more harmful. Ultraviolet radiation, even though they come from the sun, they are harmful. Why? Because they have a shorter wavelength, so they can cause skin cancer. But ordinary radiation that we come across daily, on a day-to-day basis, they have a longer wavelength and they travel short distances, and the dose is small. So you can't have it from handset or TV. Skin's glands. Skin's glands are about 3 or 4 on either side of the urethra. That's where the urine comes out in the female. Just behind the pubic bone. Now, these glands, like I said, they secrete PSA, prostate-specific antigen. And that is why prostate-specific antigen is not specific to prostate alone. We know that. But we don't tell many people because we don't want them to neglect the reading. Cancer of the skin's gland is known to exist, but it's about 3 in about 300,000 people. And because the glands are so small, the cancer doesn't spread from there. It tends to be grabbed in there. It tends to even attenuate there. I cannot say it's 0 because there is documentation that some women reported with a mass there. They took the mass, they did histopathology, and it came out to be a cancerous condition. But it's not common. It's very, very, very rare. It exists, but it's rare. I think that should be the answer. It exists, but it's rare. 0.03% or 0.0003% is not 0%. At least 3 out of maybe so many thousands. So it exists. Frequent urination. The symptom of urinary tract infection are specific. You have pain burning pain when you are micturition. You can have a discharge which is cloudy or milky. You can have a discharge that is like curdled milk. Men tend to have these symptoms more than women. Why? Because the urethra in men is longer. So urine traverses longer distance for it to be out. In women, the urethra is so small and short. So urine passes out and they empty their bladder without experiencing. That's why a woman can have urinary tract infection for many months without her knowing. First thing she has likely is to be discharged, not even burning sensation. But if she has that, definitely it's an infection. If she has a discharge, it may not be urinary tract infection, it can be a vaginal infection, because the distance between the urethra and the vagina is so short in women. And they tend to have vaginal infection more frequently than men because the distance from the back passage to the vagina, we call the perineum, is also short in women. So we always tell women that if you want to clean yourself after defecation, wipe backwards, not forwards. Because if you fall, you are likely going to contaminate your birth canal. So the urine color of the urine also. But when you have a deep colored urine, it doesn't mean that you have an infection. It means likely, 98% likely that you are dehydrated. So you need to take more water rather than. But if it burns, check, do a urine analysis. You may be excreting some crystals. I had that one. I was in South Africa one time. I was having some burning sensation. I said, I cannot be infected. I have no reason to be infected. I took my urine to a laboratory. They did, and they found ascorbic acid crystals because I was taking too much fruits. You know, South Africa, they have fruits. I was taking too much fruits, and I was secreting the ascorbic acid, which is the same thing as vitamin C, into my urine. So I stopped the fruits for some time, and I was okay. So just check if you have these symptoms: discharge, painful micturition, frequency of micturition, in particular at night, something is wrong. Yeah.
Thank you.
Thank you.
Dr. Garba, we are indeed very, very grateful to you for tonight. I want to say a very big thank you again to my Lord, the Honorable President, for the privilege of chairing tonight. I thank the event planners, especially Mr. Chris Ogundare, the MC of tonight, for a job well done. Thank you very much. I'll now yield to my Lord, the representative of the Honorable President. Thank you, my lords, for your cooperation too.
Yes, thank you, my Lord Mole. Thank you for holding the fort. Excellent evening we've had. Most educative, very deep. Of course, I will again thank the doctor. You've given us some light and some hope. We'll try to build on it. Thank you. The gentlemen will round up this evening. The night is quite spent. But please, for tomorrow, I hope we'll do better than we did today. We have 3 different resource persons coming in tomorrow. And so, please, come in a bit earlier than you did today. Not a bit, come in quite earlier than you did today, so that the resource persons will not wait for you and will not stay up till now, tomorrow. So thank you very, very much. Call on my Lord Belgore to say the closing prayers before the national anthem.
Lord, I'm most grateful. Thank you very much. Please, can we give my Lord a round of applause once again? And please may we have the Honorable Justice A.O. Belgore, JCA. Okay, we can take the mic. I guess we can take the mic to him. Yes. Please, he'll be giving us the closing prayer before we sing the national anthem. Thank you.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم وبه نستعين ربنا عليك توكلنا وإليك نبنا وإليك المصير بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين وصلى الله على سيدنا محمد وعلى آله وصحبه وسلم تسليما سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين.
Thank you, my Lord. Just before we go and before we stand up for the national anthem, please, we have one brief announcement. My Lords, I'm pleased to inform your Lordships that you now have an official email address with the suffix @courts.gov.ng. So it will be the name of the justice @courts.gov.ng. And this is an innovation that was introduced by the ICT committee, ably headed by my Lord, the Honorable Justice J.H. Sankey, and members of the ICT unit. My Lords are now invited to see the members of the ICT personnel at the help desk between now and Friday to have your new emails configured onto your phones, your tablets, and other devices, so you can then receive emails using your new email address, which is at courts.gov.ng. Thank you very much. Secondly, my Lord, as usual, the dinner will be served in the usual the Soho restaurant, which is downstairs on the second floor. At this juncture, please, may we be upstanding for the national anthem, and then we close. Arise, O compatriots, Nigeria's call obey, to serve our fatherland with love and strength and faith. The labor of our heroes past shall never be in vain. To serve with hearts and mind, one nation bound in freedom, peace and unity. My Lords, thank you very much. We wish you a safe and wonderful night. Thank you.